Hello and welcome to the Cardiometabolic Echo Session 9. I'm Nicole Earhart, one of the adult endocrinologists here at the Diabetes Institute. And today we're really excited to have Laura MONTOUR, our family medicine doctor and obesity expert, talk to us about diabetes medications and weight loss, and also our other medications that are used for pharmacotherapy for weight loss. Additionally, we have our panelists today, which include Savitha Subramanian, who's our adult endocrinologist and resident lipid expert. We also have Lorena Wright, who is the director of our Latinx Diabetes Clinic and also an adult endocrinologist. And we're really excited to have Karen Munger here today as our dietitian nutritionist. She's also a certified diabetes educator. So without further ado, go ahead and start our didactic, Laura.
Our talk title specifically is Beyond Glycemic Control, Promoting Weight Loss Using Glucose-Lowering Medications. So we're definitely going to focus on some of the diabetes-specific medications, but because this is my wheelhouse, I'm going to definitely go over some of the anti-obesity agents as well that we can use for our patients with diabetes. I have no financial disclosures for patients, other providers. This is a very special field for me. It's a kind of personal mission, but I did grow up as a child with obesity, and also I'm Native American, but growing up on my reserve, the impacts of diabetes and obesity has really driven my passion in this field. Also, as Nicole mentioned, I'm a family physician. I've been a family doctor for 13 years, now solely working in obesity medicine the last 2 years. Our objectives, we're going to go over the preferred medications to use when we need to get weight loss. We're also going to discuss options to combine things if our A1C is up, and we're also going to discuss some benefits, and we'll go over side effects. Mostly we're going to focus on GLP-1 receptor agonists, but I will touch on the SGLT2 inhibitors. I know we had a great session with Dr. Branch earlier in the sessions. When we're treating obesity, weight loss is not just eat less, exercise more. Obesity is now recognized as a chronic disease, just like high blood pressure and diabetes. Basically, why it's much more complex than this is when we do get to a certain weight, and whether it's genetics, lifestyle factors, or some medications that cause weight gain or lack of activity, when we do get to a certain weight, our body will remember that weight. And there are some rare people that can have a reset of their set point, but most of us, unfortunately, that is going to be a barrier for keeping weight off. So specifically, we know when we lose weight, our metabolism slows down. So the body adapts to take less calories. Plus also the stomach will start to produce more ghrelin to make us hungrier. We know also from research that ghrelin will go up with time, and it can stay elevated even years after weight loss. Also, when we exercise, we know that the body becomes less efficient burning calories. So keeping weight off, exercise less, eat more, doesn't consider, again, that big picture with all of these hormonal factors. So again, very key, I think, when you're managing weight. This is a great chart to have just on hand. I use it very frequently in clinic, but also when you're guiding patients when they do have various health issues. This is from the ACE obesity guidelines, but you can see just little percentages of weight loss, even 5% or 3%. We have significant improvements in various health issues. Usually when I'm working with patients in clinic, 10%, if you notice, hits most of these targets. So I usually over the year try to aim for at least a 10% weight loss. But again, great chart to have on file. Also just 10% weight loss in terms of the prediabetes aspect, because we have many patients with metabolic syndrome and prediabetes, we know will reduce risk of diabetes by 80%. Most of us are familiar with this, but just so we're all on the same page, these are the various classes of overweight and obesity. BMI still is not the greatest measure, of course, and the field, I think, is slowly evolving. And now in a lot of obesity clinics, we are monitoring not just the weight and BMI, but body fat percentage. But that is something down the road we may see updated to this, but these are still the classic breakdowns. I just wanted to point out differences in ethnic groups, and Asian American in particular, their risk can be much higher for certain health issues, even at lower BMIs. When we're talking about treating weight, another great slide, I think I had presented this before in previous lectures I've given, but it's from the Obesity Medicine Association. And it's nice, it gives you the stepwise chart on where we might be looking in terms of how much patients want to lose. Because that's the thing too, patients may come in and say, I want to lose 100 pounds or 150 pounds. And knowing that the metabolism is going to slow and we've got these adaptations that happen, those goals may not be realistic. So typically when patients eat less, exercise more, we can see, and there are rare people that can go above this, but 2 to 5% weight loss is what we may typically see. When we start doing more intensive programs, Weight Watchers or Noom or diabetes prevention program, the 5 to 10% weight loss is definitely typical. When we start adding pharmacotherapy in addition to the lifestyle intervention, these tools are getting better and better as we speak, but typically about 15 to 20% weight loss is what I would say may be achievable. Patients with diabetes, unfortunately, metabolically, they may not lose as much as patients without, but I do think that a 15-20% goal is not unreasonable. We do have endoscopic therapies as well that are available. A lot of these are not permanent. There's a balloon. There's still a lot, I think, that we're going to get from this type of therapy. It's not something that specifically we do in our clinic, but it does still yield a good amount of weight loss. And then up at the top, surgery. Surgery is not for everyone, but it's definitely something you may want to think about depending on how much weight the patient wants to lose or needs to lose based on their health condition, but also we have to consider insurance criteria there as well. This is just a further kind of breakdown of the similar concept. And specifically, I like it because it still emphasizes lifestyle across the board. No matter what the stage, that's still going to be a really key part of how we manage weight. But we should be thinking about medical therapy just the same as the Obesity Medicine Association. We want to think about it at a BMI of over 27. But again, some of your Asian American patients, you may want to think about it even sooner. This is a little bit outdated, this slide. We don't actually have leucocerin available. It was taken off the market due to cancer risk. It's a little bit controversial because we know obesity and our adipose cells actually do drive cancer risk themselves, but unfortunately it's a tool that we can no longer use, but the rest are still available. And now, of course, we have the Wegovy or the semaglutide. Moving on, for lifestyle, again, I'm not going to go into detail. We have a session, one of my colleagues in obesity medicine is going to be presenting the details about the lifestyle treatments, but it is essential no matter what the stage, and it should involve multiple disciplinaries. This kind of chart on the side here goes through the different aspects. It is important to have all hands on deck and support for our patients. Just thinking about lifestyle therapy alone, the Look Ahead trial is a pretty famous trial, and intensive weight loss management with especially a multidisciplinary team and lots of education and support. It's really has been shown to help patients keep the weight off, because again, that's the hardest part really. We've got our patient, they want to lose weight, and when we're thinking about starting medical therapy, I think this is a good place to start. We got their diagnosis, again, BMI over 27 with comorbidities or BMI over 30. Really important is to think about what medications are they on, and could there be something that they're taking that could be causing weight gain? So really key, every single patient I see in consult, are they taking weight promoting medications, and is there an option to change to something different, and would that help? Getting the diagnosis, that's easy. We know patients may benefit, but we also want to still, based on each person's characteristics, choose therapy based on that. But also in our patients with diabetes, we've got so many great tools that will lower blood sugar and assist with weight loss. Choosing those agents preferentially is definitely ideal. This is a further breakdown looking at various, and there are so many different charts and things. If certainly if you wanted more information, the Obesity Medicine Association has more detailed charts, but there are many medications basically that we prescribe, and in the endocrine and diabetes world, insulin, sulfonylureas, those are definitely agents. They're essential. I get patients, and when I tell them that, they're like, oh, I need to stop. These are still beneficial, insulin in particular, because obviously the risks of really uncontrolled blood sugar in those patients is not ideal. But if we can use another agent or try to reduce it with adding something, that's ideal. Also, just to point out, antidepressants are definitely one of the big triggers as well. In particular, I would say all the SSRIs can have some potential. Bupropion, which is an SNRI, is really the only one that we can see that has weight loss. Fluoxetine or Prozac has been shown some benefit, but in the long run, again, they still all could have the potential, but it's risk benefit. Definitely, I would avoid paroxetine or Paxil, mirtazapine, Remeron. Those are really significant weight gain medications. Also, the birth control, that's another biggie that I see patients coming in who are on Depo-Provera. Switching them to something different can really make a huge difference in their weight. Lots of considerations. Oh, and beta blockers, another class. Obviously, metoprolol is a great agent that we use a lot, but carvedilol or nadolol may have less obesogenic potential versus metoprolol. So some of my patients switching, that can make a difference. When we're using medical therapy, the way I look at it is it's similar to an antidepressant treatment. Sometimes we start patients and after their 6 to 12 weeks, if they don't get a response, if, say, we use Prozac, we could switch them to the sertraline or Zoloft. So they're not all created equal. So if someone fails one, it doesn't mean that the next one is going to be a no-go. We do want to aim. So if you do decide to treat, you definitely want to make sure that the patient loses at least 5%. Some of the drug pamphlets will say 3%, but 5% is the standard in a lot of the guidelines that you want to aim for to say that this is a tool that's working and the patient should continue. Also really key, once you find a tool that works, because we know the metabolism slows, we know the ghrelin is going to go up and patients will have a very high risk to regain, long-term treatment is definitely what we need to prevent patients from regaining the weight. Combining agents is also useful. So some of ours are bupropion, naltrexone, and phentermine, topiramate. So I look at it and I explain to patients, if you have someone in coming with hypertensive urgency and we want to get that blood pressure down, or even the A1C, we may use 2 agents. So similar kind of idea with anti-obesity agents. It's recommended that when you are starting these treatments that you want to evaluate the patient every 3 months to assess the efficacy, of course, of treatment. Also, hypoglycemia, we're going to talk a little bit about too, and I may get some thoughts from my endocrinology colleagues, but that's another concern I think a lot of people have when they start using these with patients who have diabetes or even without, but we'll talk a little bit more about that. When we're choosing diabetes medications, this is a great list that kind of goes over what medications will cause weight loss, which ones are neutral, and of course the ones that we know notoriously cause weight gain. We've heard so much about the SGLT2s, the GLP-1s, of course metformin, an old school agent, but still can help. Usually metformin alone, it's about 3% weight loss on average is what patients may see. I've never prescribed this even as a primary care doctor or the other ones, but definitely good to know about these other tools and their weight neutrality or weight loss potential. This is a big breakdown here of all of the FDA approved medications for weight loss that we have. Before we get into all the juicy diabetes tools, I wanted to just highlight some of these because it may help with our case that we're talking about as well. You can see, I think the biggest barrier is cost, insurance coverage, cost, and in particular, a good tip is, and I don't know if Dr. Wright mentioned this in our meeting last time, but the Glycemic and Contrave brand names, those ones, is a savings program through the company, but it's still about $120 a month. I really think the only one that may be worth it for some people is the Glycemic because it's just once a day, but the Contrave, it's 2 tabs twice a day. And I feel like people just end up not being compliant and it's just easier to prescribe them separate versus the Contrave. You can see all of these medications, of course, have side effects. Orlistat is another old school one that unfortunately a lot of insurances still say, oh, you have to try that first, which is really unfortunate. All it does is really decrease fat absorption. It's not doing anything appetite-wise. So unfortunately has a lot of undesired side effects and certainly vitamin issues that can come up as well, vitamin deficiencies. We're going to talk a little bit more about phentermine in a second. And again, I'm going to also mention this topiramate. Before we move on, big thing also with Glycemia, which is the combo pill. On the website, there is actually a risk evaluation and mitigation survey program through the FDA. So if you are prescribing it, it is something that you may want to do. It's basically just going through a checklist that this medicine is not safe in pregnancy. And if really it should be prescribed like Accutane, like 2 forms of birth control. If you are going to prescribe that, you may want to do the risk evaluation mitigation survey for that. And then naltrexone, bupropion. I know a lot of us are familiar with bupropion. If they have a history of seizures, that's really the biggie. Or eating disorders like bulimia, if they're having vomiting, there may be higher risk of electrolyte issues and maybe seizure. Also glaucoma risk. And with the naltrexone, if they're on opioids, that's the biggie. Basically, the naltrexone is an opioid blocker and it just won't work for those patients. But it can be prescribed separately and patients usually do pretty well compared to the Contrave brand. This is just an extension. We're going to go into detail on this a little bit further, but of course we've got liraglutide. One thing to point out, the GLP medicines, I just want to highlight, they are approved for obesity as well as diabetes. The doses for obesity, though, are much higher than what we use for diabetes. A big part of that is, and we're going to talk about this GLP hormone, but a big part of it, I think, is because the appetite, again, as we lose weight, ghrelin goes up, hungrier, and the GLP is such a great appetite reducer. I think those higher doses are just needed to fight against those hormonal shifts. I think is probably the most feared, and I certainly feared this medication even after becoming certified in obesity medicine. It's a really old school medication. It came out in the 50s. And we still use it to this day because it's cheap. Many of our patients may not have access, and out of pocket's about $15 a month. There are different ways we can administer it. So there's a tablet, a capsule, and then there's another tablet that was released in the last few years that's meant to be taken before meals. We often, and Nicole and my endocrinology team may speak to this, but we mostly use the tablet, and really, we will always want to use the lowest dose possible of any medication. So what's nice about the tablet is if the patient pays the $15, they buy that tablet, what we usually do is start them at half a tab. So you get more for less. I've used 15 and 30 milligrams, and they're supposed to be like resins, so they're absorbed slower, but a lot of times insurances don't have them. I think the 37.5 is still the classic. The 8 milligram tablet, though, I have some of my patients who may be a little bit more sensitive to stimulants. They may benefit from that lower dose, but you just have to take it before meals, so it's just more dosing. Also, it's a controlled substance. So just like anything like Adderall, if they've got a history of substance abuse, you want to be careful and probably not prescribe this medication. This is another thing maybe Nicole can speak on to after, but in patients who smoke, some of the experts in my field often find that they may develop a tolerance, like they break down the medicine maybe just a little bit differently. Again, I don't have any specific data on that, but patients who smoke may develop a tolerance easier than people that don't smoke. If tolerance happens, it's usually within the first month. That's the other thing. For considerations, there's definitely renal considerations that we've got to keep in mind, but no hepatic adjustments necessary. And contraindications, really structural heart disease, again, if they've got really bad anxiety, but if they have stable, even coronary artery disease, these medicines can still be used. I still collaborate with my cardiologist colleagues, but they can still be used in stable. Definitely, you don't want to prescribe it to someone who's got atrial fibrillation or, again, unstable heart disease, uncontrolled high blood pressure. Hyperthyroidism is another contraindication. Also, our patients with mental health issues. I have had patients get psychosis on this before, bipolar, or any patient with significant mental history. You just want to be a little careful with that. And of course, this is not safe in pregnancy as well. This is a study that's worth reading. We don't have, unfortunately, really great quality studies to look at long-term use of phentermine. When it was approved by the FDA in the 50s, it was only approved as short-term use. So that's why we all get scared. This is a short-term medication. We can't use it longer than a few months, but obesity is a chronic disease. And in this field, and what I do every single day and across the nation, my colleagues, we use it longer term, because if you take that away, the ghrelin's going to be back up, metabolism is going to be slow, and the patient will regain the weight. This retrospective study looked at an electronic health record, and they used thousands of patients, almost 14,000. And they used on-label, so short-term versus off-label long-term use. The patients that stayed on it longer lost the most amount of weight versus the short-term. but also the risk of cardiovascular disease or death was, out of 14,000 patients, was 41 events. So the risk was still very low. I know this is another thing that I worried about as well as I started prescribing this. Again, we don't have any really hardcore studies to talk about this and to study this, but when we look retrospectively, even back in the day, they were using 90 grams of phentermine and really high doses. When we look at that data, especially compared to like in other amphetamines, methamphetamines, there is really, I'd say, a minimal risk of abuse or even drug cravings when patients go off of these meds, even high dose. However, again, if your patient has a history of meth addiction or something, you definitely probably don't want to use something like this. But for the general person, risk of abuse is still very low. We've got a few more slides to go, but this is a really helpful tool. When we use phentermine by itself, we definitely get good weight loss, but like I mentioned, when we combine these agents, we're going to get higher percentage of weight loss. So most times, if we can, if the patient tolerates it, we would use both of the tools together. It's not FDA approved to prescribe them separately, but we do every single day, and I'm sure Dr. Enhart does as well. It's not exactly like Glycemia, but we get very similar benefits. We actually don't know all the ways topiramate works for weight loss. It does seem to have a dopaminergic effect. It makes soda really flat. So patients who drink soda, it can be really helpful to get them off of that. It does seem to have some metabolic benefit as well. But I really feel people, when they're on it, the reward pathways, they just feel like, oh, there was a pizza or I drove by this place. They're just not as interested, or they can resist that a little bit easier. Topiramate can increase risk of kidney stones, so just make sure they stay hydrated. I usually avoid it if they've got a history of kidney stones. I've had several patients who do end up getting that, unfortunately. Very common. Patients will describe numbness or tingling. Word finding difficulty is pretty common. It is a medicine that's used for mood. Your patients who have mental health issues, you may want to consult with their psychiatrist or just be a little bit more careful when you're prescribing that. There are some vision side effects as well, glaucoma in particular, to be aware of, and also dizziness and drowsiness. Dr. Earnhardt might speak to this as well, but I usually will dose it at night. It can still be dosed during the day. I know your patients who may use it for migraines, they may use it during the day. It can be, but that is potentially a side effect as well. No special dosing for liver. If they go on topiramate and they're doing well, if you decide to stop it, you want to taper, because theoretically there is a risk of seizures if you just stop it suddenly. We talked about the pregnancy implications, and typically for weight loss, especially compared to the Glycemia, the dose we use is about 50 to 100 milligrams. GLP is a very important hormone we've discovered in obesity and diabetes. We do know from research that patients who have diabetes and obesity, there does seem to be lower levels of GLP-1. To some extent, we also see some lowering with weight loss. I always tell patients, and this is just a helpful tip for patients who don't want to wear CPAP, leptin, which is secreted when we sleep on a circadian rhythm, leptin also has some effects with this GLP hormone. So any kind of sleep issue is definitely going to downstream have some effect on GLP. Also, I want to mention GLP because bariatric or metabolic surgery, part of the mechanism as to how that works is it increases GLP hormone. And when patients come in and they're like, okay, I want to lose weight, and we talk about the GLPs and are like, okay, so when can I stop it? And there's still complexities after surgery, but with surgery, there's going to be more permanent changes, whereas the medications, they have to continue. Otherwise, if we take it away, weight goes back up. I wanted to just highlight two functions as it ties into weight. The GLP does help with insulin sensitivity, and also when we eat food in the small intestine, the GLP gets released to go to the brain, and it says we've got food, and we get that fullness satiety signal. It overall slows how food moves through the gut as well. We've got two approved. Many of us may have heard from our patients about Wegovy. As far as I've heard, it's still on back order, very expensive, really out of reach. Also, Saxenda, the same thing. Many of our patients don't have access, but needless to say, we do have these two medications approved. What's exciting though is we are going to see newer and newer tools that do similar things that are getting even better. This new agent which some of your patients may talk about as well, tirzepatide, which we'll probably talk about later on in these sessions, is going to be better than these ones. So really exciting time to be in weight management. We all have heard the general contraindications, personal or family history of medullary thyroid cancer or multiple endocrine neoplasia to or pregnancy. The medullary thyroid cancer, people get freaked out many times after the visit. I always tell them that this is in mice, the data is in mice. And I always tell them when I prescribe it, because when they get the pharmacy stuff, if you don't talk about it, they'll get really scared of them. But it was in rodent studies. There hasn't been a direct correlation. Of course, you don't want to use it if they've got those contraindications. And this is just highlighting a study in JAMA published earlier this year comparing the two. And we can see, and from our other sessions, we see semaglutide is definitely, or the Wegovy component is definitely stronger weight loss than the Saxenda. We've also seen some of these charts for diabetes. We've got so many GLPs to choose from, and I'm not going to go through this list, but there's a lot of them. From the other sessions, we've learned also just that dulaglutide does have a good amount of weight loss as well. If you're looking at other options, that could be another backup plan for patients with diabetes. Lots of newer ones, I'm sure, coming out as we speak. And then briefly, I want to touch on this, but again, we're going to talk in detail down the road, but we do now have a new tool for diabetes. I haven't prescribed it. I don't think Dr. Earnhardt has prescribed it, but it is something that's going to be pretty exciting that we're definitely going to want to talk about later on in our sessions. In a second, I'm going to touch just a little bit on mechanism, or sorry, before we do that, we'll do the comparison. So what's exciting is the amount of weight loss is much higher than the semaglutide, of course. A1C change doesn't look that much different from semaglutide, fairly similar, but again, really exciting just the amount of weight loss that patients with diabetes have seen with this medication. I wanted to talk about tirzepatide. So it's a combination treatment. So we've got our GLP-1 plus what we've got is a GIP, it's called. And most of us may have heard of this, but it stands for glucose-dependent insulinotropic polypeptide. And GIP is, and I really think from my reading on this, like the two of them we know help with insulin secretion through the pancreas. We eat foods, GLP gets released from the gut, and so does GIP. So part of the mechanism we know for diabetes control is related to this pancreas. I still feel a little confused, and again, we're going to talk about this a little bit later on, but there are still differences because one will increase glucagon, one suppresses it. Also, together, the two of them help with beta cell preservation. From what I was reading in particular, there's still more to learn about the potential of the GIP medication, but that two together, it's just been revolutionary, which is pretty exciting. So Nicole and my endocrinology colleagues may comment on this as well. I know a big thing that I see from many patients, also PCPs, is they really don't want to prescribe GLPs for patients, especially without diabetes, because they worry about low blood sugars. In the pamphlet, it'll definitely say that is a risk, but in general, the risk is quite low. However, I was able to pull this information up, and it's a systematic review, but generally risk of low blood sugar was more common when we combine metformin. So again, they have really high A1C. We start two agents when we start two agents together, but also when you use insulin. And maybe at the end of the talk, we can talk about how much we should lower insulin, because that's the other consideration is we need to adjust insulin when patients are started on these other treatments because their blood sugars definitely may go down. Typically, I hear from most endos, it's 10 to 15% of their dose. It really depends on, again, on what their A1C is to start. Very common constipation is a side effect as well, nausea with the GLP medicines. And there is a rare risk. I've had a few patients, unfortunately, get pancreatitis, which could happen with this medication. I'm not going to go into detail about the SGLT2s. To be honest, I'm still, even after all of these lectures, I still feel fearful of this medication. It's been really helpful to, again, learn through these sessions, but there's so much benefit to these. There is weight loss associated. So definitely if a patient has coverage, it is a really great tool that you could use as well to help assist with weight loss. Lots of cardiometabolic benefits. The last thing We need to adjust insulin when we start adding medications together with their diabetes medications. 10-15% is usually what I get quoted from most endos, and I usually collaborate with them when I'm adding them. But again, my colleagues can maybe comment on that. A lot of our patients with diabetes may have high blood pressure, and their blood pressure is going to start to go down as they lose weight. So you don't want to also miss that, and make sure the patient's monitoring their blood pressure during weight loss. Again, we're going to have more nutrition discussion down the road in other sessions, but a big thing that can happen with these GLPs that I see is people just don't eat and they can get dehydrated, and we can see protein malnutrition. And if our muscles are not getting the fuel, our muscles are so important in metabolic rate, it's not going to be good for anyone. So it is good, I think, to have that dietitian supporting you, because your patients can just not eat and they're like, oh yeah, I'm losing, but it's not good down the road. Also, just tidbit, some patients who may not tolerate GLP medications, Dr. Earhart will often screen, and I will definitely sometimes do this as well. I don't know if there's any more data that Dr. Earhart can share, but potentially that could be a reason why some people are not tolerant. Also, what's cool with Ozempic, because that one can be really strong, the fact that you can do microdosing with the pen. So you don't always have to go 0.25, you can just count the clicks. That's huge for many patients. And if you had someone that didn't do well, if you go back and try the microdosing, that can be huge. Also, don't forget about gallstones. If patients are losing weight rapidly, more than 5 pounds a week, that can stimulate gallstones, just like patients who lose weight rapidly after bariatric surgery. Last tidbit, avoid gabapentin. It's very weight promoting. We always want to have lifestyle included with any medications. Try to choose diabetes medications that are going to cause weight loss or are weight neutral. And you can combine these medicines with patients who have diabetes. So don't hesitate to think about adding them to your patients. These are just some great resources for patients on obesity.
Laura, thank you so much for that great presentation. And a lot of those questions that you were asking to the group, I think are going to come up a little bit in the case discussion. Some questions that I answered in the chat that you might actually weigh in on. In people who are losing weight, do you ever stop the medication? How long have you ever used a weight loss medication for?
Okay. In my career of obesity medicine of 2 years, I would say 2 years. But before that, I definitely, as I've gotten interested in this field, I would say I have some patients with phentermine in particular, like 5-6 years. But I just see so many patients, they get on phentermine, they do really well, and it's stopped, and they just gain everything, and then they come to see me. So if the patient is benefiting, they should continue.
I think that's a great point. The study that I mentioned was the Concourse study, is our study with Glycemia, which is phentermine topiramate. And we do have up to a 2-year extension, but that's our osteoporosis medications. We don't know how long to continue things. So I think it's similar. I tend to do things cyclically because you see most of the weight loss for most of our different classes of medication at around 9 months. So I'll do a year and then maybe I'll de-escalate or hold, and then I have a low threshold to restart. But we're really focusing on lifestyle and movement and everything. So they may not keep off the 30 pounds they lost, but they may keep off 20 pounds. And then I feel like that's the right balance, because I do think what we don't know is those few points of raising of heart rate, the few points of raising of blood pressure, if we use it over 10 years, does that increase our cardiovascular risk? That's what we're always weighing, especially as we're talking about the cardiometabolic echo.
Again, it's not a highly robust study, but that electronic health record, it's worth reading for sure. Just talking about long-term use.
Yes. And unfortunately, what I will probably never have a prospective study, which is what we really need, because the good news is that we can get phentermine fairly cheaply for our patients. But the bad news is then we don't have that same resource to do those randomized control studies to really show clear benefit or harm. We definitely can do big database analysis. Then the other question I think that people were wondering about was, what is your threshold to escalate medication? How do you titrate your medication?
So patients usually lose the most amount of weight. And I kind of toy with this. Again, I'm hearing from experts in our group here and just my own experience, but I tend to ramp up if they're on semaglutide, like ramp up to 1 milligram. I don't just sit them at 0.25 for months and then escalate. I don't think that's wrong necessarily, because again, the appetite control is pretty intense. But if they're hungrier, as patients are getting, because again, appetite does pick up as we start losing weight. So I think the hunger also is a cue, because you'll notice patients will be like, oh, I feel a little bit more hungry, or it's hard to keep this calorie restriction. So yeah, I usually ramp. I think last week we had the case with liraglutide. I just ramp up to 1.8. I don't keep them at 0.6 for months and then move.
Great points. And I use they're not losing at least 1 pound a week or 4 pounds a month, and they're not having symptoms as a ramp up. Again, I agree. Something like a liraglutide, where our liraglutide at 3 milligrams, which is our weight loss dose, we don't necessarily have. So I'll definitely typically ramp up to the 1.8 over the course of 4 to 6 weeks based on symptoms. But again, if we're talking about other things like phentermine or topiramate, I will escalate if their weight loss is plateauing. And similarly, if with the liraglutide, if we have an opportunity to put them on a once a week, some glutide, then I would switch them over, because I've definitely seen significantly more weight loss outside of what is reported in the studies, which is a 4 to 6 pound difference in certain people, which I think we're still trying to figure out why people respond better and everything as well. We could keep discussing this, and there's some great questions going on, but I want to go ahead and move on to our case report. Jessica, would you go ahead and start the case discussion for us?
Absolutely. Thank you. I'm Jessica Karp, and I'm a primary care physician, family medicine with obstetrics, and I work at HealthPoint in the Des Moines clinic, which is called Midway. I'm presenting a 59-year-old female, originally from El Salvador, who came here 30 or more years ago and has no insurance and has uncontrolled diabetes. I love to find my patients with uncontrolled diabetes and present them to ECHO and find ways to improve their diabetes. So thank you for letting me present. It was clear to me that something needed to change with her diabetes care, and my ideas are adding more insulin. And we'll talk more about her case to get farther with that. She has type 2 diabetes with hyperglycemia. She has severe diabetic retinopathy. And she also has microalbuminuria, polyneuropathy. So she's had diabetes for a long time and has end organ damage from that. She's got hypertension, osteoarthritis in her knees, and a history of back surgeries. So it limits her ability to exercise. She walks with a funny gait. And then she's got hyperlipidemia. In preparing for this presentation, we found out some things about her medication. So she is on Lantus. She's at 35 units. We just titrated her up slightly to 38 units, but that gets to her max dosing based on her units per kilogram in terms of over basalization. So that's as far as I've gone there. She is on Jardiance, which is empagliflozin, 25 milligrams. She's on metformin, 1,000 BID. And then it turned out I thought she was on max dose Victoza, and I was in the process of trying to switch her to Ozempic, but she was actually only on 0.6 milligrams of Victoza and hadn't understood the directions to increase. So about a week or two ago, we got her to increase to 1.2 milligrams, and the plan is to titrate up to 1.8, and that's the daily injection for her. She's also on lisinopril 20 milligrams daily and atorvastatin 20 milligrams daily. She's got no allergies. Her mother has diabetes, so they didn't get into how bad the diabetes is, although her mother's still alive and lives with her, is in her, I think, 70s or 80s. And then her mother also has osteoporosis and no family history of heart disease. She works at a hotel. She said she works 5 days a week, but then she also said 18 hours a week. So I'm not entirely sure. Her mother's 91 and lives at home with her now, as well as her husband. And then her education is high school level, although it sounds like she's taken some community classes beyond that. She's married, doesn't use tobacco, no alcohol. You can see her vitals show that her weight is 74 kilos, which puts her at a BMI of 33. Her blood pressure was 130/80. Most recently, you can see her glucose was 266. She reported that her fastings are usually 170 to 230s. And then evening, when she checks a postprandial, they're in the 300s. That was most recently. Last month, she had an A1C of 11.1. Her GFR is normal. Cholesterol was 177 with LDL of 101, HDL of 42, and triglycerides of 200. And then you can see I added a little table there that shows that essentially her diabetes has been fairly uncontrolled for as long as we have data on her, since 2017. The best we got, and I don't know if this was an error or what was going on, was in 2019. She got down to an A1C of 7.9, but generally she's been in the 9s to 11 range and up to 13.7 for her A1C. She had a foot exam, which was normal in October last year, and a retinal exam that she's been keeping up with ophthalmology because of her disease. She had a PHQ score, which was negative, and she just saw the dentist recently. She says she's had education for diabetes and has seen the nutritionist. And when she gets offered more nutrition visits, she's kind of like, I know what to do. Although in reviewing her food history, there's definitely nutrition improvements to be made. In terms of the social services pathways, the only thing that kind of I identified for her was the cost of medications. We'll talk about that a little bit through our pharmacy because she's uninsured. Some of the challenges for her is that she has no insurance. So I hope I'm not revealing secrets about community health centers. This is on the record, but off the record, community health centers get special pricing because they're nonprofits, and community health centers called 340B pricing, which means that some of the medications they get at a discounted rate. And for people who have insurance, sometimes the insurance reimburses for that medication at a standard or average rate, in which case the pharmacy then benefits because they got the medication at a cheaper rate. And it just so happens that our pharmacy, because it's a nonprofit, what they do is they create a sliding scale for people who don't have insurance. And that means that depending on how much money they make, they can slide in their sliding scale to have deeply discounted rates. And then our pharmacists are particularly wonderful. Occasionally, even with a sliding scale, medications are very expensive and they'll say, that's unreasonable. Can you pay a quarter of that or something like that? Her medications are affordable considering how much they would be if there was nothing like this, but it still is adding up in terms of the cost that she needs. She was prescribed a CGM late last year, and she said it was uncomfortable. It bothered her while she was sleeping. I think she had it on for 2 weeks, and that was also a giveaway from our pharmacy where they gave her the monitor, and I think maybe they also gave away the reader for her. Unfortunately, she hasn't dropped it off, so I couldn't even see the 2 weeks of data that was gathered. She said she'd maybe be willing to try again, but I'm not sure if that's where we're going to be barking up that tree, but it'd be really nice to have that CGM data. And then she has said that she really can't check her blood sugars or won't check her blood sugars during her day at work and really only checks in the mornings or evenings. Another reason why CGM would be helpful, and that might also impact her interest or ability to do insulin in the middle of the day if she's at work. And she did say that there has been some stress at work because there's been understaffing, but her PHQ score was 0. Interestingly, I had my nurse help me gather her meal information, and I got kind of a cursory, like for breakfast, she eats cereal. At lunch, she eats salads. So super simple. And I started digging in with her because I was like, well, Echo's probably going to want a lot more details than that. It turns out she eats a bowl of Honey Nut Cheerios, and then she'll often have a banana with it with some whole milk. Or she'll eat instant oatmeal. And I asked a little bit more, is it the kind that you get from a packet that has flavors like cinnamon apple? She said, oh yeah, that kind. And she'll mix that just with hot water. Sometimes she'll have a scrambled egg with lettuce or broccoli. When she has that, she has toast. If she has toast, she has 1 piece of white toast or 2 pieces of wheat toast. So she does differentiate those. Banana, whole milk, she drinks coffee occasionally or water. And then her snacks, she reported carrot or celery. And then when I probed further, she dips that in ranch, just a little bit of that with water. And most of the time she eats lunch during work, and that's either at work or in the car. She does say that 1 time a day she'll eat at McDonald's or something like that. And that's when she has a diet soda and something else that she gets from McDonald's. But she said that was just once a week. And otherwise she'll bring stuff from home, white rice mixed with vegetables or chicken. And she says on the weekends, she does eat more vegetables. I'm not sure how that comes in. She does like to drink lemonade. And what she'll do is she knows she shouldn't have too much. So she just does a quarter of the cup of lemonade and then fills the rest with water. And then she'll have another fruit snack in the afternoon, banana or apple. And then at home, she eats whatever her husband cooks, which is heavy on the meat, chorizo beef or meatballs, a little bit of rice, which is white rice, or sometimes potato salad or pasta salad. So this isn't all in one day, but she was reporting multiple things that she eats. And then in the evening, she has a snack, which is either fruits or nuts, sometimes a fresh mango or papaya. If it's dried, it'll be 2 or 3 pieces. If it's fresh, just 1 plum, and sometimes she eats sunflower seeds. So I think that if I asked her that again this week, she might report a variety of different things based on what she told my nurse and then what she told me, but that's at least what she told me so far.
Jessica, thank you so much. That was a very thorough presentation. I have one question. What was her duration of diabetes? How long has she had her diabetes? Do you know? And then I'm going to throw it to our nutritionist, Karen, if she has any clarifying questions as well, and then open it up to the group briefly.
I have in our system diabetes in 2007, but I don't know if that was when she was first diagnosed.
Great, thank you. So definitely over 10 years of duration though. Karen, any particular questions for Jessica? Otherwise, I'll open up to the rest of the group.
One question I have for Jessica is she was concerned about the overbasalization, and I think maybe again my endo colleagues would agree with me, is that when the postprandial is in the 300s and the fastings are 170 to 230s, we probably are already there. So a concern is any other intervention, again, whether it's the increase in the Victoza or altering the diet, and especially because she has a job that has some activity involved in it, the risk of hypos goes up. When I have patients who are trying to lose weight, one of the things I do emphasize is every time you're hypo, you have to eat to correct the low, and that is working against your weight loss goal.
That's a great question. Has she ever experienced hypoglycemia? Does she have any fear of low blood sugars? Thanks for bringing that into the discussion here.
I don't think so. It's not something that she's related, and I don't think it's one of her fears or concerns. And she hasn't mentioned, when I get into 100, I feel hypoglycemic. She hasn't said that.
Okay, great. Anyone else have any clarifying questions?
I have a question. So she has all these snacks, and I always ask them whether they are hungry. Do they feel hungry in between meals? And is that why they are having this snack? Or is just because sometimes they are told that because they have diabetes, they have to eat and not to skip meals or not to skip snacks. And at times they just have these snacks because they were told that they need to. So do we know whether is it because she's hungry or why is she having snacks?
Great question. I'm not sure.
I have a question.
Go ahead, Savita.
What is her medication adherence? I know you said she's self-pay. I guess she's paying cash for her meds, or maybe some she's getting from the pharmacy with your 340B pricing. She's on a lot of medications. What is her adherence? Do we know?
Yeah, I think that's a really astute question. I think that possibly why she was so well controlled in 2019 was she was taking all of her medications. I do know that at the middle or fall of last year, she was traveling to El Salvador. During that time, I'm not sure that she took all of her medicines, and that might have contributed to some increase in her A1C. At least now she says she is taking, and she doesn't have any plans for future travel. So that is something to be keeping in mind for her each time. Then I think there was a question about her insurance. She has no insurance. And Dr. Earhart, if you want, I can share the pricing just verbally that I got from my pharmacist. Essentially, because of her sliding scale, she's able to get a 60 to 90 day supply of every medicine that's on this list, including the Victoza, for around $10 or less. That's an incredible amount of savings compared to what it would be, but it still is $60-ish of her money for a 60 or 90 day supply.
Great information, Jessica, and great question, Savita, about barriers to taking the medication, especially as we talk about steps moving forward. Jessica, do we have any recent finger sticks? Because you have been escalating the liraglutide a little bit, and I'm just curious if her fastings are still above 150, 200 at this point.
No, the most recent was prior to increasing the liraglutide to 1.2, and we haven't heard back from her since that happened just 2 weeks ago.
Okay, great. I'm going to go ahead and do a quick recap so people are aware, which I'm sure of the case. So this is a 59-year-old who was originally from El Salvador with type 2 diabetes of greater than 10 years diagnosation, complicated right now by pretty severe hyperglycemia. She has a history of severe diabetes retinopathy with some macular edema. This will be important as we're talking about meds. She's got further complications of microalbuminuria and polyneuropathy. Her activity seems to be limited given her history of the knee arthritis and history of back surgeries, but she is working. It seems like she's pretty active with her job, and she did a very good description of her nutrition, and she is being purposeful. So I think that's also what I saw when you got her history. She's really choosing things. I think that's really important when we're going to be talking about the nutrition aspect of it. Then you see her medication list as below that we'll go over in a little detail throughout the case. Our patient individual characteristics, her BMI is 33. Although we're going away from BMI, it is just that quick look that yes, we think she's probably insulin resistant. The good news is she may have some microvascular complications, but she's not developing end-stage renal disease yet, and we want to present that. She is moderate age, she's 59, but above the age 60 is usually considered a higher risk person, and she's 1 year away from that. Her most recent A1C is 11, so significant hyperglycemia with an A1C greater than 10. She does have all these diabetes comorbidities, and potentially limited mobility. This is all complicated by her lack of insurance, although she's being very well supported by the federally funded health clinic and her pharmacy there. So that's great news that we have that access for patients. And we're taking a look at her cardiometabolic risk. She does have her total cholesterol less than 200, a lower HDL at 42. Her LDL is fair control at 101, and her triglycerides, I'm not sure if that's fasting or not, are above our goal of 150. It does appear that on one hypertensive medication, she has good control with her blood pressure. The first question we always ask is, does this person produce insulin? And for the take of time, we're going to say, I think we can fairly say that she is mostly insulin resistant. We're not worried about insulinopenia, although she has had more than 10 years of duration of her diabetes. So always keep that in the back of her head. If we believe she's taking her medications, we're not seeing any improvement of her blood sugars. Then for her, she's still younger. So I definitely would say if we can get her to 6.5 without low blood sugars, but the caveat in this case is, Savitha, what would you be aiming for her A1C right now, given her, specifically her retinopathy?
So this is somebody who, as was pointed out, chronic hyperglycemia, meaning A1C is above 10%. In such folks, I will set an interim goal, which is not anywhere close to 7. I would say to her, with the most recent A1C being 11%, and I think that's where she's run, I'd say if you get to 9%, we'll call that a victory. So it's always in steps. You always reassess. This is how I do it. So you set a goal for a few months, and then once they get to that, you reassess and then set a new goal, and it's just moving the goal forward so that it's attainable rather than say you need to be at A1C 7%, because the risk of suddenly dropping someone's blood sugars, especially if they've been chronically hyperglycemic, it can worsen retinopathy if she has it, because it can make the blood vessels in the back of the eye leaky. And I think in one of my presentations, I mentioned this early on. So just keep that in mind. Small attainable goals is what I would say. Well, I guess that's what you have on.
Great summary there. Yes. And now we're going to focus a little bit on non-pharmacological intervention, and we're going to just specifically focus on small changes from a nutritional standpoint. I really do say that we should ask people like you, that 24-hour recall, you found so much about the patient. I do a nutritional recall at most of my visits for my patients living with diabetes, because by targeting a small change they can make in their lifestyle, you're going to get just as much bang for your buck as for a medication. And I really believe that, but it has to be their decision. Otherwise, you're just talking at the patient. So they really have to think about it. And our job is to ask them how successful, if there was any barriers to that change at the next visit. These come from the diabetes prevention program. I am a diabetes prevention trainer. I have a handout, which I will provide through our community resources, that basically teaches basic, simple things. And I use them as brief snapshots, and based on a patient's education, I might choose to focus on something. But I do think we really should focus on portion sizes, and an easy way to do that is just to talk about the healthy plate. I think you guys know the healthy plate concept, but I'm going to challenge you guys to bring it up in the discussion using a 9-inch plate and doing half the plate with vegetable, thinking about only half a cup of the starch and then the size of the palm of a hand, or half a cup of your meat portion. Really telling them, especially when you're out at a dinner, put half of it into the go box. If you're still hungry an hour later after you eat that smaller portion size, go ahead and eat more, but most of the time then your stomach gets to catch up. I'm not promoting any site, but for my health fairs, I was able to purchase for less than $2 a healthy plate. So that portion sizes, people like to leave the clinic with something. So if you have any additional resources in your clinic to buy small things like that, I have found that having a healthy plate to give to the patients is very helpful. The other things, I think instead of just saying you shouldn't eat this, you shouldn't eat this from her recall, we should teach her how to label read. Then she can make the best decisions when she's at the grocery store and she's picking out her food choices. And I think that's what we see with her diet. My quick and dirty that I can go over in less than 5 minutes in the clinical visit is know the serving size and know the calorie for it, so that you're not eating too large a portion or eating 3 portion sizes. And the next thing we do is we want to look at the fat calories, because the fat calories have the most calories. And a quick and dirty is you want to avoid those that are high in saturated fat. So I just use greater than 10% saturated fat is maybe not the best food choice for you, and consider limiting or excluding it. If it's more than 20% of your 2000 diet, I say the quick and dirty is maybe that's something to limit the portion sizes or exclude as much as possible. Especially for my patients with diabetes and prediabetes, looking at the sugar, carb, and fiber content. There's no recommendation from the ADA about daily sugar intake, but less is better. So I just tell people the quick and dirty, if it has more than 10 grams of added sugar, it's probably a lower quality food. And so that's something to look at on the label. And then the higher the fiber, the better. But greater than 3 grams of fiber per serving is also another quick and dirty that it's going to probably not peak the blood sugars as much. If you noticed, I went over that in a good 30 seconds. You can definitely do that and then give them a handout on label reading, tell them to put it on their thing, and then talk to them about what they discovered in the foods they were eating the next time. And just point out some of her food choices, but I wouldn't point them out because that's just going to make her feel deflated. Choose one thing and then she'll go and find those things out herself. This was just my slide saying you want to really base it on their educational level. So sometimes I will say a lot less, sometimes I'll say a lot more. We know we don't want to just focus on the total calorie restriction, but I do think knowledge is power. So a lot of times I will tell people that we have to be 500 calories deficit a day on average to lose half a pound to a pound a week. So if they understand that broad concept, if it works for them, they might think about calories and dividing them up per meal if that works for them, or they may just think about it more in portion sizes. I do think giving them a quick look at things is very helpful. And again, this is from the diabetes prevention program material, and it's in that handout and everything. If they do want to plan their meals, this is something to think about from a calorie and fat content thing. In her case, the quick and dirty tells us her Honey Nut Cheerios is over 12 grams of sugar per serving. So she might just be able to say, hey, I'm not going to do that, despite the fact that the label says good for lowering cholesterol, which is true because of the type of fiber they have added. But again, this label fooled her because when you look at the sugar content, it's as much as probably Lucky Charms. So you have to think about that. Similarly with the oats, again, always marketed for the lower the cholesterol levels, but the added sugar, especially with the flavor, is the problem. Karen, can you tell us, she's doing fruit, but how much sugar is in a banana?
What all the food lists say is a small banana, which is considered under 6 inches, which are not what you find in the grocery store, are in excess of 20 grams of carbohydrate. So basically, when people say to me they have a banana, I always assume it's 30, 40 or plus more grams of carbohydrate, not a lot of dietary fiber. So again, mostly all sugar carbs.
Yeah, and these are good sugar, it's natural sugar, but we talked about it actually in our first session that if we can aim for no more than 10 to 15 grams of natural sugar per 3 to 5 servings of fruit a day, we're going to help the blood sugar control. So those little changes, if she can just alter the portion sizes of her fruit, may actually bring her sugars down just as significantly. And then just to point out, she could put a half an apple in her cup of just the plain oats, and she's going to still get the fiber and she's going to get that natural sweetness, but the total sugar content is going to be less. This was just my example for fat content. Many people say they can't eat skim milk, but if you just look, the total saturated fat is 1% versus over 10%. Maybe splitting the differences starting at 2% milk, but you still get a little more calories and some fat calories. But just having that conversation and giving them the tools for the label reading so they can make the decision. Similarly with that ranch dressing and everything. Karen, any other thoughts from a nutritional standpoint before we move on to the case medications?
One of the things that, again, whether we can get the continuous glucose monitor back on the patient or if she can use a blood sugar meter, is sometimes just having the patient check a blood sugar pre-meal and check a blood sugar 2 hour post-meal. Because one of the things about, for example, the breakfast with the scrambled egg, that protein hit can help reduce postprandial glucose. Of course, if we have a lot more protein and vegetable, again, thus the plate that we were looking at earlier, we often see these lower postprandial glucoses, both because of how the food is digested, as well as we're not eating necessarily as much carbohydrate at that particular meal. So seeing the impact of, again, a pre-meal to a 2 hour post-meal glucose number. And what I tell patients is don't care what the number is. I don't care if it's 100, 200, 300. What I do care about is what's the difference, because the bigger the rise, in essence, the worse that meal is for that person, and the lesser the rise, again, typically I'd recommend under 40 or 50 milligrams per deciliter between pre to post. We then know what food works better for you, and they get to discover this for themselves.
Great point. And we've talked a lot about using the post-meal sugars as a guide for glucose control. And in someone who's doing fairly well, the American Diabetes Association does recommend less than 180 2 hours after the meal. ACE guidelines are 140 to 160 is optimal. Again, we don't want to discourage people. So I liked how you said you're looking at the change so you can assess the food until perhaps their diabetes get better controlled. And then the one other thing, the reason I asked Savitha about her A1C goal is that the question is for maximizing her weight loss, which was one of the questions, and optimizing her diabetes management, what GLP-1 would you use? So I actually think she's on the right GLP-1 right now with a slow titration because we don't want too rapid of change of her blood sugars. And with our semaglutide 2 milligram, we're going to get more A1C lowering and more weight loss. But what we have to remember is, especially in those with background retinopathy, there was initial worsening of retinopathy in the SUSTAIN 6 trial. And there's actually an ongoing study looking at semaglutide and those with baseline or retinopathy to see the effect. The next question, I'm going to start with Lorena here. This is a hard question. Would you even use semaglutide in this patient who has severe diabetes retinopathy at baseline with, let's say, a very slow taper?
I would continue with the diet. Then once she is better controlled, as Savitha said, once I get A1C that is lower, then I might escalate therapy, but I wouldn't right now. I wouldn't use semaglutide.
Exactly. And that's how I was thinking about it. We use the liraglutide for the next 3 to 6 months. We get her to a better glucose control. And then when she's had some times at 9, then 8, then potentially we add the semaglutide. Now, if she stays above 10 and she is very insulin resistant, we may need to go to a weekly GLP-1 for more A1C lowering, but the goal would be is not to drop the A1C too quickly. I think that's a great point. I do use semaglutide in people who have baseline retinal disease because the long-term look at it shows that it actually is protective over time. It's just that initial transient worsening. So we just want to be careful and do the best advantage to our patients with a slower taper and being even more aware in this particular population. My next question, which I'm going to ask Savitha, is she's on dual therapy. And like you said, there's cost for her medications. She does not have known cardiovascular disease. Do you think she needs dual therapy with SGLT2I and with GLP-1 receptor agonist?
I was going to bring up SGLT2 inhibitor therapy for a different reason. I'll mention it here and then I'll try to answer your question. SGLT2 inhibitors are not super great glycemic lowering drugs, maybe 0.6% A1C lowering. And especially in people who are hyperglycemic like this, it probably is not really doing much. What I usually do is I try to get them to a better glycemic level before I introduce these agents, or if they're on it and they're like this, I would take them off and then reintroduce it another time. There's different ways to practice diabetes, but they're just not good glucose lowering drugs, especially at this level. So in a roundabout way, in her situation, would I use an SGLT2 inhibitor now? Does she need it? She is primary prevention. She doesn't have any cardiovascular disease. And I forget, does she have microalbuminuria? I forget. But would I use, well, I think simplicity always works. In her situation, if the first goal is to get her a little bit better with her glycemic management, I might not use the SGLT2 inhibitor at this point, and then instead see if we can do a different thing with her insulin therapy and then maybe reintroduce it another time if glycemic lowering is necessary. But if she has albuminuria, and if she does, there's definite benefit. So yes, you can use dual therapy, triple therapy, all of these drugs. Modern diabetes management is something like metformin, SGLT2, and GLP-1 receptor agonist are good combos. But in her case, her hyperglycemia is the thing that needs to be addressed first. Then a lot of this can get resolved and drug reintroduction can happen down the road.
Exactly. And those are exactly the points that I was going to make as well. For glycemic management, given her basis of glucose, given her high sugars, we don't actually think that the SGLT2I inhibitors are going to be doing much for her right now. And if cost is an issue, especially, this would be a medication that I may hold. However, she's just about 60 and she does have hypertension and hyperlipidemia. So for primary prevention, she is high risk when she hits age 60. And then she does have, I thought, the microalbuminuria, if I understood correctly. So for non-glycemic management, at some point, we may want to introduce this medication. I think it was good that she was on it, but we may want to hold it at least in the short term and then reevaluate from a cost and her glycemic control when to reintroduce this medication. So great point, Savitha. Exactly what I was going to make as well. We've had such a great discussion. I just want to briefly go over the insulin management. So you astutely have increased her to 0.5 units per kilogram. And what the American Diabetes Association recommends, what we see is when you go above 0.5 units per kilogram, there's little benefit and increased risk for hypoglycemia. So you are correct. At this point, you've maximized her basal therapy. So the next step in her case would be to add insulin with the mealtime. And I think the issue, as you pointed out, especially if you're going to do 3 times a day, is the shot burden, especially if she's already on a daily GLP-1. But what you want to think about is, how do I initiate it? Okay, so what would I do? What am I comfortable with? We've seen really high sugars still if we believe she's taking the 0.5 units per kilogram or 0.4 units per kilogram before that. So what would I be comfortable with? If we do 0.5 units per kilogram, which is 38 divided by 2 is the total daily dose, that's 18 units. And if you divide it by 3, that's a starting dose of 6 units. A lot of times in our algorithms, we see the starting dose of 2 to 4 units. But I think by thinking about it this way, by her insulin resistance and her absolute weight, you can start a little bit more aggressively, but not so aggressive that the patient's going to be nervous about it. Quite frankly, given her diet choices and the higher carb intake, I would be very comfortable starting 8 to 9 units on this patient with breakfast and dinner. But I think 6 is a nice, comfortable starting spot. I may go down to 0.4 units per kilogram on the basal insulin, but I think since her BMI is above 30 and she has normal renal function, I'd be okay keeping her at 0.5 units. So that's how I think about it. Now, in her case, though, I like using 70-30 mix and even 50-50 insulin. I don't want to drop her glucoses too much either. So that's why the 6 units with the first and the last meal of the day, or even just with the largest meal of the day for starting would be okay. But I would do 0.5 units per kilogram total with the mixed insulin, so 20 units twice a day. And that is, again, 6 units of prandial insulin. I think that would be safe. I use weight-based calculations to say, what would I be comfortable with? Many people who have type 2 diabetes need 1 unit per kilogram or more. But in a lean person who has renal disease, they need very little. Most of the algorithms you see for diabetes management are based on avoiding hypoglycemia, and they have to do it as a catch-all for all those patients who may have little insulin needs versus lots of insulin needs. So part of this course is really understanding how to select the insulin dose, so to think about it critically. Lorena, I'd love to hear your insight as well, but Savitha and I tend to have the most difference in insulin management. So I was curious your thoughts on this. So go ahead.
I want to go against the grain and say, actually, this is a situation I'll agree with you.
Ah, we're agreeing on everything today.
Yeah,
what a great session.
This situation, I think pre-mixed insulin is probably the best way to go. And I think we should ask Lorena what she would do.
I like this. I agree too. That's a good combo.
Okay, well, that's a great point there. And we already talked about the overbasalization. And again, we just wanted to say, once the diabetes is better controlled, if weight loss is a goal, Laura, is there a particular medication you might use in this person in addition to the GLP-1 if she needs more weight loss?
Well, again, the insurance is a barrier for her and again, lots of our patients, but I potentially think maybe we didn't really get information on her sleep, but I think actually naltrexone, and that should be bupropion, might be something. She's got a lot like caregiver, and again, I don't know her mental health history, but I might potentially think about the naltrexone bupropion. I think she could still do phentermine topiramate, but it's just the cost, having to pay out of pocket for the phentermine. Plenity is a device. It's not a medication, but it's an approved device for weight loss. It makes the patients feel full. And again, that one because of cost.
That's all great points. One thing I will point out is what I've seen for cost for phentermine is for the capsules for 15 milligrams, it's about $20 to $25 with a good RX. The same thing with the 8 milligrams. And I will start those in people who I'm worried about anxiety or insomnia just for 2 weeks. Then I might move to the tablets because that's even cheaper then. It ends up only being $5 to $10 a month. Most patients will be okay with the slight increase in cost for a month or so to make sure they tolerate the medication well. So that's a lot of times what I do with the phentermine. We want to just highlight this person has 8.6% 10-year risk of heart disease or stroke. So appropriately, her primary care doctor has her on a statin, and because of the microalbuminuria, and she's on a lisinopril as well. So she is being maximized from a cardiovascular risk reduction standpoint. So our Rex, we've already talked about. Consider in the long term a weekly GLP-1 receptor agonist, and consider switching her over to 70-30 mixed insulin for now. We were talking about how to titrate insulin. So what I tell people is if you have any sugars less than 70, immediately go down. And I usually do it by 4 or 5 units of insulin, just based on their weight. And someone who's really resistant, I might only go down by 2 units, but usually it's 4 or 5. Also, when I'm doing weight loss, I usually do a 20% reduction of people who are well controlled on their insulin before we even start. And I allow that higher blood sugar because I don't want them to have any risk for low blood sugars. Then I'll tell them, if you're seeing a lot of sugars in the 80s to 120s, especially in the morning, go ahead and try to sneak down on your insulin dose by 2 to 4 units. You can always re-increase it, but I specifically will also say if you have 2 or more morning fastings less than 100, go ahead and decrease your insulin, especially the basal insulin, because we don't want them not to be able to exercise, and we don't want them to have to be feeding their insulin. Those are the simple techniques I give them for avoiding low blood sugars. And again, I'd much rather have them running 100 to 180 rather than having less than 100, which is still at goal, but a risk for hypoglycemia when they want to exert themselves. I think in this case, label reading is going to be key for her, and just some small changes goals that she makes. I agree. If she doesn't want to use a personal device, if she had insurance, you could write PRN lunchtime insulin, and then she'd be on her 3 or more shots of insulin a day and qualify for it at this point. But you may want to use a professional CGM, particularly our Dexcom G6 does have the real time available so they can see their blood sugars for those feedbacks. And that is something I often use for people that don't use a personal device or don't have access to it because they're only on oral medications or just on basal insulin. You may want to support her by sending her to nutrition, or if you have the time, you can also provide some of that knowledge, hopefully, given what we talked about today. I'm going to say this ends session 9 of the Cardiometabolic Echo, and what a great session it was today. Thank you all for joining us today. Bye.